welcome to this session on EPA. And This session has been brought to you by Singapore Physiotherapy Association. And speaker today is a very well-known personality to us, as we all know, Dr. Go Aching. And I will give more introductions on him to you all. But prior to that, I think you will find your speakers to be on mute. Uh, so you will not be able to speak unless you unmute your speaker. We will try not to have everybody speaking because that could be disrupting. And what if you have any question or anything to ask Dr. Aching, you may post it in your chat and we will try to address your queries at the end of the session. Okay. While more people will be joining in, we have about 50% people who have joined in right now based on the registration that we had. And we also have some interesting and overseas guests joining us from as far as from Mexico, from Bhutan, and from Kuwait. Welcome to our good overseas friends to this great session. And so today, Dr. Go Acheng is going to speak about some new trends, developments, and clarify a few fundamentals about ultrasound therapy. Though he may not require much of introduction to many of us, but to some new ones, the new generation, I certainly would give him a brief introduction. Dr. Acheng has been extremely passionate person about electrophysical agent. He holds over 35 years of experience, and out of that 22 years of working in Japan, where he currently is the Dean and Professor of Iryo Sosei University. Also, he is currently holding the position as President of International Society of EPA, which is a special interest group under WCPT. Dr. Go graduated in 1981. I believe many of you were not even born during that year. In 92, he got his master's from Sydney. In 2003, he completed his doctorate from Curtin University, Australia. He has been speaker, guest lecturer, and authors in various publications. And we were honored to have him as a keynote speaker during our WCPT Congress in Singapore. So I won't hold you too long between you and Dr. Acheng. Welcome, Dr. Acheng.
Thank you. Can you all hear me?
Yes.
You're all able to hear me? Okay.
Others won't say yes. You won't probably hear them. They're on silent mic.
Okay. I'm just going to share the screen, sorry. And then we'll get started. Can you see the presentation? Are you able to see that?
Yes, Dr. Acheng.
Okay, I'm just going to minimize this. Before I do that, I'm just going to minimize. This always gets in the way. So, okay. Now, sometimes, first of all, thank you for the invitation. I feel very old after you said that some of you are not even born when I was studying as a physio. So, and I am old, but it's good to be back and to be able to talk to all of you again, especially on the topic of ultrasound. This was actually the topic of my PhD studies, and a lot of what I'm presenting to you is the data is from the PhD study. So I'll try and get to that as soon as I can. But before that, there's a few minor introduction things that I need to do. So I just need to introduce the topic of ultrasound to all of you. And I want to sort of warn you a little bit that whatever you think you know about ultrasound, therapeutic ultrasound, by the end of this session, I'm going to challenge you so that by the time you finish, you are going to question a lot of what you are doing and what you actually know about therapeutic ultrasound and what's written in the textbooks. and what is being taught in classes at all the universities around, not just Japan but Singapore, Australia, and so on. So um, keep your mind open. If you have time, go and get a cup of coffee and put it in front of you. You're gonna need that caffeine rush, because I know some of you will be surprised by a lot of things that I'm gonna say today. You might not even agree with what I will say, but keep yourself awake. Bring coffee, bring something next. Well, except alcohol. Don't drink beer, because you'll fall asleep during this session. Okay, now very quickly, why did I pick ultrasound? Because it is one of the most used modality in electrophysical agents. That's when I started the research in early 2000, almost 20 years ago. And I wanted to start with something that people were using. I wanted to start with something that people may not fully understand. What there were gaps in the research at that time. Like, we don't know about what dosage to give for ultrasound. Most of us, including myself, we stick to one dose. It's always 0.5 watts per cm squared for 10 minutes, or 1.0 watt per cm squared for 5 minutes. All of us have this fixed in our brain. It didn't matter what the diagnosis or condition was, we just stuck with that, and we keep on using that same dosage again. Some of you are more perhaps conservative. You always pulse it at 50%. You're not sure, so you pulse it. So I'm going to challenge all that today and tell you that there is a better way. There's a better way to make to to determine the dosage for treatment. And hopefully by the end, I'll present to you 3 models that you can think about. We'll come to that soon. So this was actually a very informal um, uh, survey that I did. Hospital A, Hospital B, they are both Singapore hospital. One of them is SGH, the other one is NUH. I won't tell you which is which, but I think some of you can guess. Use daily, use monthly, use yearly, not use. You can see that uh, um, it's about 50-50. So when you total, 50% are not using it, 50% are using it, but not frequently. So use daily is still there, but compared to other modalities, definitely is much. Other EPA modalities is being used more frequently than the rest. When you look at who's using it, basically the MS people, sports people. Surprisingly, the cardiopulmonary group, I thought it was CP was cardiopulmonary. It's not. I I don't know why they're using it monthly, but anyway, this is SGH and NUH, so the data may not be fantastic, but we've actually got a new survey of this, and that's actually in one of my publications. If you're interested, you can just search for it, and you'll find that the usage for ultrasound is quite high still. Now, before I go into the main dosimetry right at the bottom, very quickly, I'm just going to remind you on terminology, because it's important that you understand that, so that when I'm talking about it during the dosage, you will know what I'm talking about. Transducer, I think everybody knows that. Power is measured in watts, but we normally use intensity as the dosage. So we go by watts per cm squared. Then I'm not sure if you can see this video. This is just a simple test that you can do. As the intensity goes up, you can see that, the peak is right in the middle, and then the peak intensity is right in the middle. Anyway, were you able to see that video? This is in slow motion anyway, but the same thing. As intensity goes up, you can see that the peaks right in the middle, and the water, they sort of break the surface tension, and they start to actually fly off from the rest of the body of water. So that's to show you that we measure intensity in 2 ways: the spatial average intensity and spatial peak intensity. Why are these important? Because of the BNR, the beam non-uniformity ratio, which is actually SPI over SAI, is to 1. So just before I finish that, we want to be as low as possible for BNR, so that you get a smooth feel. Now, 20 years ago, it was not as good. So it's like 10.10 is to 1. Before that, it's even like 20 is to 1. So the peak intensity right at the center there can cause hotspots. So people would pulse it so that you don't get as much hotspots in there. But the present models, the present devices, the good transducers, the BNR is as low as 2:1. So you don't have that problem of hotspot. So which means that you may not need to pulse the we'll come back to pulse in a short while. So this is continuous ultrasound at the top, pulse ultrasound at the bottom, all of you know. And because we pulse it, the intensity setting is not, it's not enough to say what intensity it is because you pulse it. You have to say what the duty cycle is. So duty cycle is only important if you pulse it. If you don't pulse it, duty cycle is irrelevant. We'll come back to that again when we talk about dosage. Then, because you pulse it, there are two more things that we have to talk about intensity, SATP and SATA. Again, if you don't pulse it, you don't have to worry about SATP, SATA. Now I keep coming back to continuous and pulse. Pulse is giving us so much problems with intensity, definition of intensity, power output, and so on. And it was only necessary because the BNR was not good long ago. Nowadays, the BNR is so good that you don't need to pulse it. If you wanted a low intensity, you just go continuous and just go 0.1, 0.2. But previously, even at 0.1, 0.2, you still will get hotspots, but not anymore. So this pulsing thing created a lot of terminologies that are really no longer relevant in the dosimetry model, and I'll come to that very soon. Frequency 1 and 3 megahertz. And that's not enough. People are saying that 1 and 3 megahertz, these are the frequencies that manufacturers will sell you, but they'll tell you there's also a 5 megahertz, there's a 3.3 megahertz, and so on. It's a bit like your iPhone. If you can see my iPhone here, every year they have to give you a new model, because if they don't give you a new model, you don't need to buy a new phone. Similarly with ultrasound, what's new about it? So the only thing they can claim is I give you another frequency. And if they give you another frequency, you may be seduced by that and say, oh, I need a 5 megahertz, so I'll buy a 5 megahertz. Is it any better? Do we need more frequencies? We'll come to that. ERA. ERA again was something from the old model where the surface of the transducer does not completely match the surface where the energy radiates from. It's quite bad long ago. Nowadays, that's almost not a problem anymore. The ERA is almost as good as the surface of the transducer. Almost all the surface will produce energy. So again, ERA is something that we don't need to talk about as much. Near field, far field, all the energy for therapeutic ultrasound comes from the near field. When you talk about diagnostic ultrasound, it's from the far field. So again, therapeutic ultrasound, near field, no problem. We know that near field has a lot of non-uniformity in the energy. Okay, this one is important. Sound waves are capable of reflection, refraction, penetration, absorption. This is just physics. But when you look at this more closely, looking at reflection, we can actually calculate how much energy will reflect from tissue interface between air and skin, skin and fat, fat and muscle, muscle and bone. You can actually calculate that. These are just simple calculations, but if you take, this is between skin and fat, fat and muscle, muscle and bone. If you take all this and you make a model out of this, and we say, this is just the examples that you can look at, but if you take a model of tissue and say we can calculate whether it reflects, it's absorbed, or whether it's attenuated, theoretically, you can actually come up with a model based on this. And I'm going to show you this. The top one there that you see there between muscle and bone, you will find that it reflects at 57%. That is important. Between soft tissue, between fat and skin and muscle, the reflection is negligible, almost negligible. You don't even have to worry about it. But between soft and hard tissue, the reflection is about 57%. We'll come back to this at the end. Just remember this when we talk about the model again. So when you look at the bottom part, this is based on no reflection at tissue interface. This is not true, of course, but just by theoretical, if you go by that, you'll see that from fat, muscle, the fat and muscle, soft tissue will take about 50% of the energy. And then the bone will take the rest of the 50% of the energy. Is that okay? But when you have reflection computed in that, you will find that almost 80% of the energy will be absorbed in the soft tissue, and only 20% will reach the bone. That's very different. 50-50 to 80-20 means that unless the bone is really, really near your treatment area, that's really superficial, you don't really need to worry about the bone, because most of it will be absorbed within the soft tissue. We'll come to this again when we talk about model. Half depths, I think all of you know. I'll just go over this very quickly. So for muscle, it's about 2 cm. Again, you can calculate that. So this one's important. People keep saying the non-thermal effects are important, and therefore pulse ultrasound is important, because pulse ultrasound is the non-thermal effect. But you have to be very careful. Non-thermal effects can also occur when it is not pulse, when it's continuous. Non-thermal effects just means that apart from the heating effect of ultrasound, which is caused by the molecules rubbing against each other, there's also cavitation, microstreaming, and acoustic streaming. Now, what's cavitation? Cavitation are the bubbles that occur in the field. What's microstreaming? Well, the bubbles, I'll go back to you, the bubbles that occur vibrate. And when they vibrate, the fluid around the bubbles will circle around it. What's acoustic streaming? Acoustic streaming is the summation of all that. So imagine you have a glass of Coca-Cola in your cup, and you've got ice in there as well. You know that after a while, the ice melts, so the water will rise to the top, and you get Coke, the dark fluid at the bottom, and the light fluid, which is mainly water, at the top. You can do something, you can stir if you want, but the better thing to do is if you hold it and you just shake it. And if you shake it and you vibrate it, the ice will start to vibrate. And the ice, around the ice will be the micro streaming. And then acoustic streaming will occur that will bring the dark Coca-Cola up to the top, and then the water that comes down. So you'll get an even mix of water and Coke at the end of that. That, in essence, is the non-thermal effects of ultrasound. Cavitation is represented by the ice. Microstreaming is represented by the ice vibrating and fluid moving around it. And acoustic streaming is where the fluid will then, the summation of all that is the fluid will then move around the tissue. And then you get, supposedly, you get this microstreaming effect, which is good for circulation and fluid and general healing and stuff like that. But remember this, the cavitation effects do not occur at low intensity. They only occur at very, very high intensity, like 20 watts per cm squared. Has been demonstrated in frogs and in other things, but not in humans. There has not been one study that has demonstrated cavitation effects at therapeutic dosage in humans. So there is no such thing as non-thermal effects. It's there theoretically, yes, but in clinical applications, in the treatment that you do, and with the devices that you have, which is really, the intensity is really capped at 3 watts per cm squared. You cannot go beyond 3 watts per cm squared nowadays. But in the 60s and the 70s, they can go as high as 20 or even higher than that. And therefore, under those circumstances, yes, you get cavitation, microstreaming, acoustic streaming. But you don't have, you have no way of having these effects in current devices. And in fact, these are actually red herrings. They're not really that important in therapeutic ultrasound. The main effect for therapeutic ultrasound is the thermal effect. And there is no such thing as non-thermal. Even at 0.1 watts per cm squared, that's still thermal. When you want to talk about non-thermal, then we talk about low intensity pulse ultrasound or LIPUS. That's non-thermal. But that has a totally different application from therapeutic ultrasound. So let's not come back to that. So let's finish that. Okay, let's do this biophysical change. Most of you that have followed me in the first lecture will understand that the way that we approach this dosimetry, anyway, or at least clinical reasoning for dosimetry, is three steps approach. The biophysical change first, then if that's achieved, then you get the physiological effect. And if you can get the physiological effect, then you will probably be able to get the clinical effect. But it goes by this sequence. If you can't get the biophysical change, then obviously step 2 and 3 would not be possible. If you can get step 2, step 3 may be possible, but it's not always guaranteed. And people may not understand that. Why isn't it always guaranteed? Why isn't it always not guaranteed? Because sometimes the choice of this treatment modality is not appropriate. Sometimes the patient may be better off doing some other treatment, or the patient is already past the phase where ultrasound or any EPA device would be able to help. So things like this have to be taken into consideration when you do clinical studies and look at clinical effects. But let's quickly go through this biothermal effect. And this is a infrared thermography. This is a portable one that you can buy and attach it to your iPhone, and you can get the same thing. But I used a more advanced, sophisticated device. And this is the thermographic image that you have. You can see from there, from the top left, 0.1, next 0.3, 0.5, 7, 9, and 1.1. This is for 1 megahertz. And in fact, when you look at the 1.1 and 0.7 at the bottom, you can see the ultrasound transducer is really black. That means it's really hot. It's black already. And then you can see the tissue. This is a pig specimen. You can see how the energy sort of moves from there going down the layer. And this is actually shown more clearly in this picture that you see here. This is 1.3 and 1.5 for 3 megahertz. I have the same for 1, but for 1 megahertz, I mean. And this is after 10 minutes. And you can see how the energy moves in the pattern is very regular. So if you want a really, really good thermal modality that produces consistently similar patterns every time you treat, ultrasound is much better than shortwave or microwave, because you can see from here, the energy that goes through here is very, very consistent. And this is what you want when you want to talk about energy control. You want it to be consistent. So that was the thermographic scan. Now I give you the graph. And this is for 1 megahertz. So you can see the top left is 0 centimeters, which is the skin. Then 1 cm below the skin, 2 cm below the skin, 3, 4, 5 cm below the skin. When you look at the colors of the line graphs, right at the bottom, black is 0.1 watts per cm squared. Then it goes to 0.3, 0.5, 7, 9, 11, 1.1, 1.3, and finally the red is 1.5. Now, this is for 1 megahertz. I'll come back to this again. There is a pattern here that you have to understand that if you don't see this graph, you may not catch it, but I'll come back to that very soon. This is a similar one for 3 megahertz. They're on the same scale. So you can see 3 megahertz really overheating the skin. And then when you go down to 5 cm, it's really almost, there's no energy left there. Whereas compared to 1 megahertz, the skin is not overly overheated. And at 5 cm, you still have energy there. So this is your biophysical change. Now, so for biophysical change, 3 megahertz, 5 cm, 1 megahertz, greater than 5 cm. It can actually go more than that. We haven't measured past 5 cm, but it can go much more than that. So penetration depends on frequency, as all of you know, but more importantly, penetration depends on intensity. So if you only have one frequency, you can still control that by intensity. But if you have a frequency, 1 and 3 megahertz, okay, you have more choices. But we'll come back to this again. Is that good or bad? When we talk about the model, I'll tell you about frequency and intensity. Of all the heat modalities, penetration is greatest for ultrasound, and it's at 5 cm or greater. And the deepest penetration is right in the middle of the field. So if you really want to penetrate really deep, you have to position your target tissue right in the middle so that you can get maximum penetration. Now the next, this is given to you before, I think I gave this to all of you. The Goldilocks zone that we're looking at here, before the Goldilocks, sorry. So 0.1 to 5.0, you can get all these effects. But the Goldilocks zone from 41 to 45 degrees, last time I did it as well. Let's come back to here again. So at 0 centimeters, this is the Goldilocks zone. This is 1 megahertz. So if you look at 3 megahertz and 1 megahertz, this is interesting. Look at the Goldilocks zone, the pink for the one on the left, 1 megahertz. That pink hits the Goldilocks zone and it goes all the way up to the purple, green. The green bars, the error bars are there. So the energy that is just nice is for 1 megahertz 0.5 watts per cm squared up to 1.3 watts per cm squared. Below 0.5 it's too little. Above 1.3 is too much. So this is the Goldilocks zone that we were talking about last time. Not too much, not too little, just nice. 1 megahertz, 0.5 to 1.3. Look at the right for 3 megahertz. The Goldilocks zone is just between that 0.3 to 0.5. Above 0.5, it's too much for the skin. Below 0.3 is too little. So the range of therapy, the range of energy that you can use for treatment for 3 megahertz is very limited because you're overheating the skin too much. And for 1 megahertz, you have actually a good range. It goes from about 0.5 up to 1.3. We'll come back to that again. So if you pass this, let's say at 0 cm, you pass that, that means energy is not too much, not too little, then let's look at below 1 cm. Try to remember 1 megahertz is 0.5 to 1.3, and 3 megahertz 0.3 to 0.5. Let's go to the next one here. So at 1 cm, you can see that for 3 megahertz, you are getting in the physiological range. The therapy, Goldilocks zone is there, but those are the intensities that we already rule out from that means they're too high for the skin. 0.3 to 0.5 is not in that range. But for the what's that funny line that just appeared? Why is this line appearing from nowhere? Why somebody's doing something to my slide? But if you look at the left, you can see that 1.3 is still there, barely touching the Goldilocks zone. 2 cm. This is the Goldilocks zone. Again, 1.3 is just touching there. 3 megahertz, you can forget about it. At 3 cm, why is there funny lines all over my screen? Am I just seeing that, or all of you are seeing that green line scribbled across my screen? Is it just me?
Yeah, there's some line, but it's okay.
It's okay? Okay, I don't know why it happened there, but
no, not carry on.
Okay. So, at 3 cm, you'll see that you're already reaching past that Goldilocks zone for 1 megahertz, but we'll come back to that again. Very short. And 4 cm, again, not that great. So, if you want to be 5 cm, 3 cm, well, 1 megahertz is just touching anyway. It's not really that bad. So, 1 megahertz, if you really look at it, look at the error bars and so on, you can get physiological effects maybe up to about 5 cm, 4 cm. But at 3 megahertz, you're looking at even less than 3 cm, even 2 cm or less than that. So 3 megahertz is really limited in the way that you can deliver energy to the target tissue. This is really, the green lines are bothering me, but never mind. Okay, so this is the physiological effects that you get. This is the same thing that I think I gave to you a few months ago. But I want to talk to you about this. Let's come back to here. And this one here. This is the summary of 1 megahertz. There are 3 patterns here. If you look, the treatment, by the way, is under 10 minutes. After 10 minutes is cooling down period. So look at the skin. it increases to the peak temperature until 10 minutes. If you continue past 10 minutes, it will continue to rise, of course, but while the treatment is on, it will increase to the peak temperature. And when the treatment is off, it starts to cool down. That's the expected pattern that we have. For shortwave, for infrared, everybody on the skin, that's what you will see. But what's important is that 1 and 2 cm, watch that carefully. It goes to the peak at 10 minutes, and after that, it doesn't drop off. It just continues to maintain that peak temperature. Even after 10 minutes post-treatment, I didn't measure beyond that. If I were to measure that beyond that, you will still find that it can continue to maintain that temperature for much longer, maybe 2 times, 3 times longer, 20 minutes, 30 minutes longer, perhaps. But it doesn't cool down. Now look at, so 1 cm, 2 cm is the same pattern. Look at 3 cm, 4 cm, and even 5 cm. Look at 10 minutes, when it goes 10 minutes, that's not the peak. It will continue to rise even after you switch off. Although it's not as much, but it will still continue to rise. And you can see that at 5 cm more clearly. At 10 minutes, that's not the peak. The peak was actually somewhere around just before 20 minutes. So that 3 pattern you have to bear in mind. Those 3 patterns will help you to decide on how long you want to heat the tissue and where is your therapeutic window. For the skin, as long as you're giving the treatment, the therapeutic window is while the treatment is on. The minute you switch off, you lose all the energy, it starts to cool down. But between skin and 2 cm, the therapeutic, once you heat it up, the therapeutic window is maintained for quite some time. In this case, 10 minutes, but it can be more than 10 minutes, 20, 30 minutes up to there. That's your therapeutic window. When you come down to look at the 3 cm, 4 cm, and 5 cm, you find that your peak temperature doesn't stop there, it continues to rise. So you can actually, even if it did not hit the therapeutic range at 10 minutes, if you continue to monitor it, you may be able to hit the therapeutic range. Or if you continue to apply the ultrasound treatment for more than 10 minutes, for example, 15 minutes, for example, you'll be able definitely to hit the therapeutic range. So the moral of the story here is if you have target tissue that's between 2 cm, for example, then 10 minutes is probably more than enough. But if you have more than 2 cm, deeper than 2 cm, obviously 10 minutes is not enough. You have to go on maybe for 15, 20 minutes to be able to get into the therapeutic range and keep it there as well. Most of us never do ultrasound for more than 5 or 6 minutes. 10 minutes is probably pushing it. Probably if you say 10 minutes, it's probably not you. It's probably the student doing it or your therapy assistant that's doing it. But you would not sit there for 10 minutes and do ultrasound. I know this from personal experience. The tolerance is about 5 to 6 minutes. And you think 5 minutes may be too short, 10 minutes too long. So some of you go by 6, 7 minutes. That's about the tolerance that you can. That's not a good way to judge. But if you look at the physics of it all, it tells you, yeah, if you want to do 5 minutes is obviously too little. 6, 7 minutes is also too little. You need at least 10 minutes or more. If your tissue depth is further, you definitely need more than 10 minutes. So we'll come to that shortly again, but let's continue with, why is that green thing still all over my screen? Never mind. Okay, so, sorry, we'll just have to circle back to this, what I want to talk about, which is the main part of the story, but to understand the physics, to go through. I'm sorry about this. We have to go through these slides and just one more. Okay, just one more. Okay, so let's look at clinical effects. That's fine. We'll skip to this picture. You've seen it before. Let's come to dosimetry. And that's the thing that I have about 20 minutes to go through dosimetry with you. This is something that I found when I started the research to be meaningless. This is clinical standards for the use of EPA. The physiotherapist shall ensure that correct intensity is chosen for the treatment to avoid delivery of excess energy to the tissues. It's nonsensical because what is the correct intensity is never clearly stated. And how do we know what's excess energy? So no one has told us this. So this was something that this was something that started me on this. Those statements don't mean anything. Of course, we know that we're not supposed to do that, but how are we supposed not to do that? No one has the answer to that. Again, there is no agreement nationally or internationally about optimum dosages for any given condition. And this one is interesting. Young and Dyson in 1990. Too low a dose will have no effect. Too high will be damaging. That's the Goldilocks principle. We know that. That's what we are talking about. But where is the Goldilocks range? No one knows. Optimum parameters for treatment dosage includes intensity, use of continuous or pulse mode, frequency, duration of treatment. But none of those, what the optimum dosage has not been established. And also we don't know how, when we vary those equipment, what are the effects, I think that part of it is not as critical as the first part. If you can answer the first part, maybe the second part would be then more relevant. But compared to things like hot pack, for example, it's just, time. Compared to infrared is distance and time. Compared to shortwave and microwave. All those things have very little parameters for you to decide. It's either one or two parameters. For ultrasound, the combination of all this is quite significant. There's so many permutations that you can think about it. I'll show you how much depth. Another one here, the depth of the target tissue. Lisa mentioned this, and the tissue composition. Now, tissue composition, I told you earlier, as long as it's soft tissue, you don't need to worry. But between soft and hard tissue, you may have to worry. But put that aside for the time being. Depth of target tissue, of course, that makes sense. How far your target tissue is would determine your dosage as well. So in the end, Val Robertson, she's fantastic. She's retired anyway, but she's been fantastic through all this. There is no justification for any of the dosage parameters that you use in ultrasound treatment, and this is in 2002. And I started my PhD around that time, and I finished it in 2003. But all those things sort of gave me this frustration about where do we go with ultrasound. It's the most widely used modality in the EPA, and yet people are saying you should do this, you should do that, and so on, but no one can give me at that time anyway, the answers that I wanted. So in order to develop this model, I broke it down and looked at 3 questions. Energy at the source, the ultrasound itself, how the energy moves from the source to the target tissue, and then what happens to the energy at the target tissue. When you divide that into 3 questions like this, then some of the answers become very easy and almost, you don't even need research to answer that question. Some of it is very clear-cut. Some of them not so clear-cut, and I at that time, and I needed to go through systematically answer each and every one of those questions. First one, energy at the source. All of you know that reliability. Second one is delivery and power physical chain. Let's look at it. The first one, energy at the source, has 2 categories: machine-related, protocol-related. Protocol means the way we use it. Machine-related, very important at the top of the list is reliability of output intensity and performance stability. Now, we know that ultrasound, FDA anyway, they are saying plus minus 20% error. In the European, they say plus minus 10%. I think FDA has now changed it to plus minus 10%. So all machines that you buy must have plus minus 10% error, no more than that. But we know from all the literature that's been done, I won't say none, most of the machines do not meet even that simple requirement. So if your machine is not reliable from week to week, whatever intensity is displayed on is displayed on your machine is not reliable, then there's no way we can talk about dosimetry. There's no point talking about dosimetry. If you want to put, if you say 0.5 watts per cm squared is what your setting is, but 0.5 is not coming out of that transducer, then there's no point in talking about intensity. So we have to be more, we have to be more demanding in the sense that whatever ultrasound machine that you are using must be reliable and must meet the performance standards. This is a simple calibration graph that I suggested everybody to do, but you need to buy a power meter. The power meter is something that you can calibrate by yourself. There's a video here, but I won't bother with that video. And all you have to do is plot your results from there. So on the x-axis, you find what's coming out from the ultrasound, the display itself, and then on the y-axis is the power meter display that you see on the left here, the black box that's there. And if you were to do a graph and you get a perfect correlation, then you know there's no error, but there's no such thing. You'll probably get something like this. So if you really, really wanted, for example, to have this is in watts. So let's say your treatment, you wanted 6 watts, for example. So when you look at the y-axis, 6 watts, you follow that all the way to the graph and you come down, that means your ultrasound display must be 9 watts. Even though it says 9 watts, you are going to get 6 watts coming out of that. And you can make this graph, put a date on it, paste it on your ultrasound machine, and then just make the graph every month or so, depending on your usage. And you will know that you don't need to calibrate, but at least you will know that you will be able to get the right output based on this graph that you're making. You can get your therapy assistant to make that graph for you every month, for example. And the ultrasound power meter that you need to buy is cheaper than sending it once to the manufacturer to ask them to calibrate for you. And also the manufacturers, when they calibrate for you, you don't know what they're doing. Sometimes they just calibrate lowest intensity, highest intensity, and they draw a line in between that. When actually we know that's not true. It's not linear, it's curvilinear. So you need more data points to get the calibration. And this simple, the video I was about to show you actually shows you that it can be done in less than 5 minutes. And anybody can do that in 5 minutes. So if you demand that your ultrasound device must be at least not really calibrated, but doing this calibration graph that you're doing, you're not doing anything to the internal parts of the ultrasound. You're just finding out what is the power meter display and what's the ultrasound display, print it out, and then you read off the graph to get what you want. The protocol related factors are perhaps more easy. I didn't need to answer most of it. There are 2 that I need to answer, but technique of application, I know most of you do. You know that there's a direct and an indirect. The direct is the one where you have contact, the one on the left, and the indirect underwater. Now we know, don't do underwater, do direct, because when you do direct, the distance from the transducer to the skin and therefore to the target tissue is constant. But when you do underwater, the distance keeps changing. And if the distance keeps changing, there's no way I can give you a dosimetry model that will be able to give you control of the energy. You won't be able to control the energy. And besides, nowadays, there's really no need to do it underwater. Again, this comes back to BNR. Because the BNR was so bad at that time, the hotspots will give you, especially if you go over irregular surfaces, you get hotspots. But not anymore. When the BNR is about 2:1, you will not get the hotspot. Even if you're doing on the lateral malleolus, for example, you'll be able to do fine. Even if it's a large transducer head, you still will not have any problems doing that. So don't do underwater, do direct contact with gel. Angle of transducer to the skin, you saw from my calculations earlier on, you have to be perpendicular. If you're not perpendicular, you're going to get reflection of all the tissue interface. So perpendicular will mean that you have minimum amount of reflection, and that's the best. The next one here is temperature. Don't bother about hot or cold, it doesn't make a difference. Pressure of transducer on skin, don't press on it like you're doing shiatsu massage. Just gently move, let the weight of the transducer contact the skin. That's more than enough. Don't press on it. Some of you, like, you're doing tissue massage while you're doing ultrasound. When you press on the skin, the tissue that's compressed, the impedance will change. That means the way the energy moves through the tissue will change. And if you're not putting the same pressure on it every time you do it, even though the intensity is the same, you're not going to be able to get control of the energy. So don't press, just have it contact and just move it lightly over the skin. That's simple. Size of treatment area. And here's something that I could not, I had to do an experiment. Do you think that the size of the treatment area matters? No, I did. What I mean by size is, when some of you move, I hope you can see me doing my hand movements here, but some of you move, when you're doing the elbow, you do that little thing. Can you all see me doing this? Are you able to see me doing this demo? I can't see myself. Dinesh, can you see me? Dinesh? Are you guys still there?
Yes, sorry, because we are muted. Sorry.
Okay.
Yeah, we can see.
Can you see me doing this?
Yes, I can see you. That's
okay.
correct.
So this is a good example. You start with tennis elbow and you start with small surface here. Then the gel sort of falls off. So you scoop up the gel, you've got bigger area here, you scoop up and you go like that. Then the patient will tell you, I've got some pain in the shoulder, so you go up the shoulder, you come down here. So your surface area, the treatment area that you have is haphazard. Not just haphazard, but there's no way you can control energy if you don't define the treatment area. And some of you, worst of all, don't even do it. You give it to the patient. And the patient is doing on himself, and he's going happily like this, talking to friends and watching his phone and not paying attention and going up and down and under and over and so on. Patients, TAs do that as well. I've seen TAs where they don't even know the importance of defining treatment area. So those sort of treatment will not be successful. But the reason they're not successful is not because the ultrasound doesn't work, is the application is so haphazard that there's no way it can be successful. So what is the optimum size of treatment area? So frequency 1 megahertz, time 10 minutes on, 10 minutes off, intensity 1.0 watts per cm squared. And there were 3 areas. I chose small, 2 ERA, that's small, medium, 3 ERA, which is the red, and then large is the 4 ERA. And I cut a little plastic template and then move within that template. And this is what you see. Look at surface. The small ERA had the 2 ERA had the highest heating effect. The medium is the red one in the middle, and then the blue right at the bottom, least heating effect. And look, as you go from 1 to 2 to 3 cm, you can see that they're spaced out. That means that size matters. If your ERA is not consistent, you are not going to be able to control the energy. And from our study, we said, keep it small. 2 ERA is what you need. So your sound head if you need to draw that on the patient's skin, draw on that, and then tell your patient, move in this area. Keep your transducer within this area. So don't go circles like this, go linear, go back and forth. That's the best way for you to control the energy. So when you look at speed, the next one is speed of moving transducer. Does speed matter? Some of you probably will say yes. In workshops, they always say, yeah, it matters. Why? Because if I slow down, they start to get hot. I move faster, they don't feel so hot anymore. That's just the hot spots that you're talking about. So that's probably a bad transducer, something that has a very bad BNR. But normal BNR, the speed, whether you're slow or fast, should not give you the hot spots. So what was the best speed? And again, I did this, and I used a metronome. Same parameters as the previous one. Slow was 60 beats per minute, so it goes like this. Some of you probably will fall asleep doing this. Medium is a bit faster. That's a bit faster. That's probably some of you doing it. And then 180 degrees is much faster. That's probably those of you that are doing this just before lunch and you're hungry and you want to get to lunch quickly. And so you're moving it fast, thinking that the faster you move, the faster the time will go. That's obviously the feeling that you get, but that's obviously not quite right. Do you think speed matters? If you keep it within a 2 ERA, the answer, the same frequency. I use 1 and 3 megahertz this time, but the answer will surprise you. Look at how the slow, medium, and fast speeds superimpose on each other all the way down to 5 cm. That means if you keep it at 2 ERA, the speed doesn't matter. How fast you move doesn't matter because the energy is contained within a 2 ERA. As long as you move side to side, you will be able to get the same heating effect, no matter what the speed is. So if you need to go fast, go slow. We recommend medium, 120 beats per minute. But of course, it really didn't matter. You can go faster or slower as you wish. So this is for 3 megahertz. The same results for 3 megahertz as well. You'd see exactly the superimpose on each other, unlike the other one. So that's energy at the source. We need to be able to make sure that our application, just touching it, no much pressure on it, direct contact method, move within 2 ERA. Don't put pressure on it, just move slightly and within 2 ERA. And the speed doesn't matter. You can go slow or fast, it's up to you, but if you keep within a 2 ERA, 90 degrees perpendicular to the tissue surface, you should be able to get good results, good consistent results. The next one, from source to target, and this is the one that I was having to struggle with because there are too many parameters. So if you look at from source to target, right on the left, machine parameters, frequency, intensity, duration, duty cycle. One in the middle, machine target tissue interface. So transmissive coupling gel, you need coupling medium. You need to have enough coupling medium. You cannot be stingy about it. You have to have enough coupling gel. Most of you don't like to do too much because it's messy on the patient. But if you don't use enough, you have a problem with it. Distance, how far away is it? And then distance only applies to non-contact. So if you don't do non-contact, distance will not be a problem. Target tissue characteristic, depth, composition. Composition, again, don't worry about it unless it's bone and soft tissue. Depth does matter. So based on those, we have to pick from here and look at what's important. And as I said earlier on, duty cycle is something that we should stop doing from today, from now. Don't do duty cycle. It complicates the whole dosimetry model. And it's not even necessary. And when you do duty cycle, how much duty cycle you have to talk about SATP, SATA, and so on. So it's just something that was a leftover from a long ago period that we still use. That's still in our machine that you buy, and the concept that we think that when you pulse it, you can get non-thermal effects, which I already told you can forget about that. Everything is thermal anyway for therapeutic ultrasound. It just depends on how much thermal you want to go. That's about it. So duty cycle was something that I felt very comfortable in dropping from this altogether. So keep it at 100%. I actually have another study to show you that duty cycle, if you go at 100% at 0.5 watts per cm squared, you will get the same heating effect at 100% 0.5, right? So I'm talking about 50% at 1 watts per cm squared. You'll get the same heating effect, but I won't show you today. It's actually there. Machine target in tissue interface. So transmissivity of the gel, we said, so use lots of gel to make sure that there's no air bubbles in between your skin and transducer. This one came up by chance, this condom barrier thing. The women's health group at Perth, during one of my lectures, asked me, they're using condom to as a sterile technique when they do ultrasound over episiotomies. So to them they feel like that condom is a barrier, that somehow when they set it at zero point 0.5 watts or 1.0 watts, they know instinctively that it's not coming out. There's a barrier. You're losing some of. It's like trying to talk to you with a barrier in front of me. You're not gonna get all that sound energy reaching you. And they've wanted evidence. So I said, yeah, sure, I can do that. So we did this, and you can see from here the control group, which is no condom on it. That's the graph that you see. This 1 megahertz continuous, and then the intensity is zero point 0.5 all the way to 11 watts that you see there. You can see that condom, which is the purple bar, you can see that it is almost linear. In fact, it is linear. It is 18% less energy that's coming up. And the condom that I used was a condom that they were using in the hospital. I brought back the condom so that I could use it. Now, I have to explain to my wife why all of a sudden I have condoms in my luggage, but I told her it was for experiments, so which was true, but that's another topic for conversation sometime. But anyway, so this condom, when I message them and say, 18%, so just up by 18% and you're fine. And there was something that was simple enough to do. It wasn't a research, it was just something that an experiment that could be done in 30 minutes, and the results were there. This is for 1 megahertz pulse, the same thing with pulse. They say they use pulse, so I checked as well. This is the same thing, it's linear, and it dropped by 25%. 3 megahertz, it dropped by 25 here, and then pulse 3 megahertz, it dropped by 26%, or more or less 25%. So that's something that you need to think about when you're putting something between your tissue, the transducer and the tissue interface. If you're just using gel, you're fine. But anything that comes in between, you really have to check that carefully. The next one is depth. So we went down to as far as 5 cm. That's what I was thinking. Beyond 5 cm, I wasn't going to go beyond that because I don't think in clinical applications you have anything that's more than 5 cm. So we stuck with 5 cm. And then, so the main parameters here that we want to consider is frequency, output intensity, duration, and depth of target tissue. So 3A, 3B, 3C, and 5A. Now, based on that, the research questions were what were the relationship between frequency, intensity, duration, and at different target depths. And we measured the skin. So the relationship between this, if you look at the literature, the relationship between temperature and intensity and duration exposure, this is what you have. You can see the gaps in that table. There's so many gaps in the table which is unknown. So there's no way from the literature that you can construct a model. There's too much unknown. There's too many gaps in the data. This is for 1 megahertz. This is for 3 megahertz. Again, the gap is just not enough for me to construct a data. So I have to go back to basics and then get the data that I want. But I use a pig model. Now, there's a lot of argument about pig models and in vivo and in vitro. I want to tell you that I don't have time to go through all of it, but if you look at the thesis, you will see that after we get the data, we then correlate back to the data that's here, and you find that the data that we have and the data that's obtained here, this is in vivo, this is in vitro, they match. They actually match, and not just match the gaps. I can fill in all the gaps here as well. So it is not a bad model to examine. It's a model nonetheless. So it's not like real life, but it's a model that we use to get the data to construct a dosimetry model for treatment dosages. So based on that, the results I already showed you earlier, these were the results that I had. But taking this result, understanding the physics, the pattern of heating and the duration and so on is not enough. We then from here have to make the model. And I'll come to that. Energy at target, clinical studies. And this is the it's really 9. Sorry, you guys. Are you guys still okay with me? Just another 10 minutes. Are you okay? You all okay?
Yes, Dr. Acheng, that's fine. Please carry on.
Okay, this one here, I'm going to spend 2 minutes on this because this is important.
Yeah, please. Yeah.
Okay, energy at target. We need clinical studies to find out what happens when you deliver energy to the target. The problem is there are clinical studies, lots of clinical studies. Some of them say yes, some of them say no. My beef with all this is that those clinical studies didn't have a dosimetry model to guide them. They were done based on just instinct, like, oh, let's do this. Some of them is like, oh, other studies have done this and they use this dosage, so we'll do that as well. That's not a good justification for dosage. It's like the doctor's telling you, here's some drugs, take as many as you like. And if you don't have any effect, take some more. If you die, then you took too much. But if you don't die and there's no effect, you took too little. So you try and you figure out yourself. No doctor would be in business if they were to do that. But physios, that's what we're doing. When you have ultrasound, we're just trying, and I think it's 0.5. Let me try, if I don't burn anything, then, it's not too much. If I don't get effect, it may be too little. But then again, ultrasound, who's taking it? It's just an adjunct to treatment. So it's like getting the therapy assistant to fill in 10 minutes of that while you do 10 minutes of other work. And then while they are doing that 10 minutes, then you come back, okay, I'm now ready to give you the real treatment, which is whatever it may be, ultrasound, not ultrasound, but not EPA. That sort of attitude bugs me. It still bugs me today. And that's what people subconsciously, maybe consciously not, you don't feel that, but subconsciously, that's what you're doing. If you don't have the dosage to guide you, why are you doing it? And more important, if you don't have dosage to guide you, why are you doing research on this when you don't have dosage to guide you? Then after you do the research, we go one more step further. We do meta-analysis, and the meta-analysis will tell you, yeah, it doesn't work. Yeah, based on data that was obtained through improper application of the energy. That bugs me. I hope it bugs you, but that really bugs me. So let's look at this. Good dosimetry, frequency, intensity, duration. These are the parameters that this is the present guideline. Low frequencies for deep tissue, high frequencies for superficial tissue. Does that make sense to you? Does it make sense to anybody? If I tell you when you come to me and I tell you, you want to buy a car. So look, I have lots of cars for you. But that car in the corner, that's a very small compact car. It's only 500cc. It can only go very slow speeds. But that car on the left, it can go top speed more than 200 kilometers per hour. That's a fast car. That's a slow car. You have to buy both because when you want to drive slow, you use that car, that 500cc. When you want to drive fast, you use the other car. Does it make sense to you? Any of you? Because the slow car cannot go fast, but the fast car can go slow. So in the same way, the 1 megahertz can go deep and superficial. Don't forget, deep doesn't mean just goes magic to deep. It goes through the superficial to get to deep. But the high frequency cannot go deep. And we really show you in the biophysics section that it doesn't do that. The high frequency is limited in the way that they can. It, in fact, is not even useful. I would not even use 3 megahertz. I would throw it away and just concentrate on 1 megahertz and learn how to control the 1 megahertz much better. The second one here is intensity. We have 0.1, over here they say it's 0.5 to 3.0 watts. It's a safe range. I challenged that. I honestly did. I did research to challenge that, and I can tell, I'm not sure whether it's here, but I think it might be. It will show you that that's not true either. Duration, 5 to 10 minutes, and usually 1-2 minutes per 10 cm squared. Who says that? You keep your area fixed. You cannot keep on changing your area. You must keep it fixed. And then you say less than 3 minutes is ineffective. Yeah, I can tell you that because you won't even reach the Goldilocks zone. You can't reach the Goldilocks in 3 minutes. So 5 to 10 minutes, we'll challenge that as well. So when I came up with this model, the principles are this: it must be simple, it must be complete, and it must be consistent. Those are things that, so consistent means keep it at 120 beats per minute, 2 ERA, contact gel technique. Complete means 0.1 to 1.5 watts. Why 1.5? I'm not sure whether I'll show you here, but beyond 1.5, there's a risk of tissue damage. Not 3.0 as what they stated earlier, it's 1.5. And I have cell studies to show you that. And then it must cover from skin all the way down to 5 cm below the skin. Now, the present model, this is a recommended dosage present model, 2 frequencies, 30 intensities because they want to go until 3.0 watts per cm squared, 10 duration, 1 to 10 minutes, depth, 6 from skin to 5 cm. Your total choices is 3,600 choices. That's not simple. But if you just keep to 1 frequency, kick off the 3 megahertz, it's just not necessary. Intensity, keep it within the safe range, which is 1.5 watts per cm squared. And then for duration, keep it at constant 10 minutes. Keep it at 10 minutes. That's the minimum time you need to do. You want to go more is possible, but below that, no. Keep it at 10 minutes. And then depth, 6 choices. And that's what you have, 48 choices. From 3,600 to 48 choices, I would prefer to have a 48 choice model. No doctor is going to give you a pill that has 3,600 dosage dosage choices. They'll just go crazy about that. They only have 1 or 2 models. 3 times a day, take 1 capsule, or 3 times a day, take 2 capsules. That's the simplest dosimetry model that, any idiot can understand that. But when you say 3,600, you need a genius to understand that. 48, maybe you have a chance of understanding that. So the proposed model for dosimetry, I told you earlier, muscle and bone, initially I thought this was a problem. That means 57% was reflected, and then 43% was transmitted. I found out later, after I finished all this, one of my graduate students was doing this. It's the other way around. It is actually being absorbed first. And when it's absorbed, we know that 90% is being absorbed and 10% is being reflected. That's if you keep it perpendicular. If you get an angle, then of course you're going to get more than 10% being reflected. So in other words, I didn't need to worry about muscle and bone interface. So that makes it even simpler. So 3 models were proposed: basic for novice clinicians, Model 2 for intermediate, which is for experienced clinicians, and Model 3 is for advanced, for research. And the difference is this. This is the same data that I had earlier on, just placed in a different way. For novice clinicians, you only need to remember 4 things. For target tissue between surface and 2 cm, that's 2 cm that we talked about earlier, around the superficial, without the presence of bone, 0.5 to 1 watts per cm squared. With the presence of bone is 0.1 to 0.5. But now we are saying even presence of bone, don't worry about it. So even less, you only need to worry about the brown box there. So between surface and 2 cm is 0.5 to 1 watts per cm. That's probably what we were all doing before, because I was always going at either 0.5 or 1 watts per cm squared when I was doing my treatment. And it was always 10 minutes. I didn't realize it at that time, but that's what I was doing. So it didn't matter. It was in that range. For things that's between 2 and 5 cm, then it was 1.0 to 1.5 watts. That brought it into the Goldilocks zone there. Now, presence of bone, 0.5 to 1. Again, may not have to worry about that. So there's only 2 things you need to remember about this model. Simple model. May not be enough. For a clinician, they say, that's a bit too simple, so I want to use it based on clinical indications. And the clinical indications here, from 1 all the way to 5, those are what's in the literature. So for wound healing, you need very low heating, so less than plus 1 degrees. For inflammation subacute, about 1 degree increase is all you need. For more chronic, about plus 2 degrees. For control of pain, a bit more, plus 3 degrees. And finally, for soft tissue extensibility, the maximum plus 5 degrees. This is what we're looking at, energy level. So when you do that, switch on the machine, and then again, bone or no bone, again, no, if there's a bone there, you don't, as I said earlier, I thought that was a problem, but it's not a problem anymore. There's no available data. I was going to continue to get data for this, but I stopped doing it once we realized that the bone was not a problem. Then depth of target tissue, where is the depth? So when you have that depth, what's the aim of treatment, which is 1 to 5, choose from that. And the table is here. So if I wanted to treat for example, control of chronic inflammation at 2 cm, the tendon is at 2 cm, for example. If you look at the chart, it'll be 0.7 watts per cm squared, assuming your device is reliable. And this is for 1 megahertz. Now, in the same, by the way, the one that's in red, those are not actual data, but they are projected, calculated from the data that I have. So there's a few gaps in there that you have. For 3 megahertz, you can see there's a lot of gaps in there. Now, why do I have 3 megahertz data? Because people are still using 3 megahertz. So I thought I'll just put it out there, even though I don't recommend it. But this is what you have. And you can see that for 3 megahertz, you can't really do that much. You only up to about 2 to 3 cm. That's about as far as you can go. Now, the advanced model for researchers is they're saying we want to be more pinpoint, more precise. We want to make sure that we are able to tell at what depth, what increase in temperature. That's more for researchers, probably not for clinicians. And it's the same thing. So if I wanted to increase the tissue at 2 cm by 2.5 degrees, then on the left, you can see that is 0.9 watts per cm squared. So that's for 1 megahertz. And on the right is for 3 megahertz. And if you were to just copy that, paste it on your ultrasound machine somewhere, and you'll be able to get, I didn't get that slide that I wanted to show you, but it's okay. It's actually the cell studies looking at the damage to the tissue. And I did the cell studies here, then sent it to, everything was prepared, stained, put on a slide, send the slides to Perth. I can't remember the university. It's not Curtin, it's down south. I can't remember the name of the university. It's quite a famous university. But there's a vet surgeon there that specializes in pathology of pork tissue. And she then looked at the slides and she rated it as damage or no damage. And the results showed that beyond 1.5 watts per cm squared, there is high possibility of tissue damage below the skin and at the skin itself. Now, most of that will recover with time. That means the patient probably doesn't even, it's like a bad sunburn, or it's like, when they touch a hot object, they have some damage and they will recover. But at the high intensities, we're talking about third degree burns at the high intensity, at 3 watts per cm squared. At about 1.5 to about 2, they're only about first degree burns. So we we answered the question, like, what is the safe limit? We said 1.5 watts per cm squared. And the model is based on that as well. Now, I know I've gone over time and I apologize. I still cannot figure out why I have green lines on my screen. But if there's any interest, I'm very happy to take some questions. And I hope Dinesh and SPA doesn't mind.
Yes, Dr. Acheng, thank you very much for this interesting share. There are a few questions actually from the floor. You can actually look into the chat box.
Okay.
I can read it for you.
I can see it. First one, you can. Second one is aqua gel pad is as effective in medium with the ultrasound gel. What can be the reason why some patients feel shooting pain during ultra despite a 3 second per revision movement?
I think there are two questions. So first is gel pad, and then the second.
Okay, the aqua gel pad I think was actually it's less messy than than the actual gel, the gel itself. I can tell you that there's not, we don't, maybe it's a bit too early. We don't have data to tell you whether the transmissivity is as good as just normal gel. We have the data for normal gel that tells you transmissivity is about 99%. Don't forget that transducer and skin interface is important. So if you start putting condoms and gel pads and so on, you are reducing the energy that goes through. And therefore, your energy control will not be consistent. So I would not at this stage, unless I get very good data to show me that the gel pad is as good transmissivity as the contact, as the normal gel, I would just not buy that. I will not use that for the time being. I'll still stick to the normal gel. Is that okay?
Yeah.
Okay. Then why do they feel shooting pain? Yeah, check your machine. Your machine may be, I don't know whether it's working properly or not, but your machine.
Is a BNR issue?
Yeah, you have an issue with your machine. So go and get somebody to check on it, or maybe buy a new one that has a good PNR. Next one, from Mexico. Hi, Andres. Oh, thank you for that conference thing. What do you think about the recent article that
Therapeutic ultrasound has no physiological effect.
therapeutic ultrasound doesn't have physiological effects? Okay. That means therapeutic ultrasound has no physiological effects. And I told you my the last part I said that clinical studies are important, but clinical studies in the absence of a dosimetry model doesn't make sense. So when you look at those clinical studies that don't have any rational dosimetry model, and they get bad results, and then they tell you there's no physiological effect whatsoever, it is not the ultrasound. It is the control of ultrasound energy that is the problem. And if we control the energy much better, I think we'll get better physiological effects. So I would put this as in the box that is not proven yet. That means physiological effects. We know if you hit it up to the therapeutic range in the Goldilocks zone, you will get physiological effects. But those studies, those articles that publish those, they may not have got enough energy into the therapeutic range. And that could be the main problem with a lot of ultrasound studies. So that's that okay?
Yeah, that's fine. And I believe the confusion probably more on clinical effect rather than physiological effects. Many of the...
That's true.
Yeah.
That's true. But again, it's a step 3. So step 2 you can't get means you can't get step 3.
Exactly.
Goldilocks zone is important.
Sure.
The next one is what about dosimetry and coupling recommendations for... Okay, I used phonophoresis when I was in a soldier performance center because the doctor that was there, sports medicine doctor, believes in it. So we have to make our own every morning. We make dexamethasone in the gel. We inject it, we stir it up, and then we put it in the fridge. And then every time we need to use it, we take it out and we scoop it on and do that. Some of you use gel. Some of them use liquid, as I did, mix in the gel. Transmissivity is the problem. The minute you start putting things in the gel, transmissivity goes down. But perhaps the idea is not to reach all the way down to 5 cm. They just want to get it past the skin barrier. So you just put that, then you put the gel on top. So you put the gel on your skin, like, or what you call it, those Voltaren gel, you put it on there. Then you put the ultrasound gel above that, and then you just start doing ultrasound. Then during the application, the Voltaren gel and ultrasound will all mix and give you a horrible white color in the end that looks very messy. But the idea is to push as many of the drug molecules through the skin. Once you get through the skin, it doesn't matter anymore. So there are many studies on this. So pig studies as well. You'll find one good pig studies on this quite some time back, I think, that shows you, yeah, you can get it through. And yes, it gets into the blood circulation as well. So not just blood circulation, but of course below the skin. So if the tendon is there, yes, you can get it there as well. Nowadays, this is already something that we know it can be done. Whether you want to do it, I don't know. if you're talking about inflammation, wouldn't it be better for you to try things like, cryotherapy, rest, protection, splints, rather than pushing through ultrasound with the drug molecules? Because when you push through, that's a thermal effect that you're going to have. You can't cut the thermal effect, it's there. And then if you're talking about acute inflammation, you don't really want a thermal effect. So the drugs are going through, so that's giving not much, but small concentration of drugs are going through, but then that's counterbalanced and negated by the thermal effect that you're also producing. So not the best, perhaps. I've done it before, and I've done it lots, and I wasn't impressed either at that time. It didn't look like he was doing. The patient loves it because when you tell the patient, you're giving you drugs through the skin, like, oh, okay, but mm, be careful with that. If you really want to do that, and there are good machines that show you using electro electrophoresis, not electrophoresis.
Ionotophoresis.
Yes, iontophoresis, sorry. Using iontophoresis, much better. And they have the whole setup. They have the pads, they have the gel in there, the medicine is there, they have the device, the dosage, everything is set. You just stick it on, switch it on, and that works. That works much better than phonophoresis, I think, iontophoresis. But you need the special pads with the drugs in there. Is there any recommendation or treatment days? Oh, that's a beautiful question. I wish I could answer you that. That's probably somebody, a graduate student may have to do that. All I can say is that, like anything that we do, patient response is important. So if you treat somebody with the maybe we start with 3 times a day because it's impossible to come, not 3 times a day, sorry, 3 times a week. It's impossible to come daily. So if they come 3 times a week, and if that works, you stick with that. If that doesn't work, then you may have to consider dosage problems. That means up your dosage. So the frequency doesn't change, but the dosage the frequency of treatment, sorry, doesn't change 3 times a week, for example. But some patient will tell you that I can't come 3 times a week. I can only come twice a week or once a week. In that case, I don't think you need to bother with EPA. You're probably better off with self-management and, uh, you know, uh, splints or protection, um, advice, ADL modification. That probably be more useful than coming once a week for ultrasound. That doesn't make sense. It's like the doctor telling you take one pill for 1 week. It's not going to work. So the energy is not enough for you to sustain whatever physiological effect that you get, and therefore dubious. But of course, if you're in private practice, you never say no. If you're in private practice, once a week come, I will still take your money, but it may not work, but I'll take your money. Once a week is better than not coming at all. But I'm making fun of that. But all I'm saying is sometimes the number of treatment days is not a simple issue as just evidence. It's also patient expectation, patient's ability to come, and the therapist's expectation, the therapist's other factors are involved in that, and then you decide on how many times you come. Sometimes it's not scientific, sometimes it's something else. So, but it's a good question. Can we have a slide dosage indication? Yeah, I can send you. You want that table, is it? Is that what you want? Can we have a slide on dosage indication? You want that table, is that right? Okay. Okay, sorry, that's not true. Jarrell, can we have the slide on dosage indication? Did you mean you want the?
No, okay. I think they want to have access to the slide.
Okay. So anyway, I think the video, you'll have access to this video as well, right?
Yeah, I think we'll make provision to have them access.
Okay,
yes.
so you play the video and you pause on it and take a screen capture. That might be the best way.
Exactly, can be done.
I can send a PDF, but the PDF is like, it's not small. It's a lot of, I think it's like 250 megabytes, that whole PDF stuff. But I'll talk to Dinesh and we'll see what we can come up with, something that's useful for you. What is the gap needed between sessions? Same thing. It's for acute, subacute, and chronic condition. I wish I knew the answer. Honestly, that's the clinical studies. So I wish if you're interested, you want to be a graduate student, come. I'll happy to take you and you can answer this question. It's not so simple as acute, subacute, and chronic, of course. You have to be more specific, like where is the target tissue? Is it like if it's a tennis elbow, it's very near the skin, that would be very, very different from something that's deeper. Or if you're looking at maybe a tendon that's like the patellar tendon, for example, that's really huge. And so there are many questions that we cannot answer with just with the models that are given you, but it's a start. Those models will then allow you to do the clinical studies to answer the question that you are looking at. So graduate studies, PhD, come. I'm happy to take you on. Will you recommend ultrasound as an adjunct EPA for, okay, this adjunct word is not a good word. Ultrasound, ultrasound, not just ultrasound, but EPA is not an adjunct to anything. EPA is a primary treatment for many things. When you say adjunct, there's always this image in my mind of, filling in time while you're waiting for someone, while you're waiting to do this patient, you need some 10 minutes to talk to someone on the phone. Then you tell the therapy assistant, please do 10 minutes, and then you talk to someone on the phone. That's adjunct. So try not to have this image that EPA is adjunct. Okay, adhesive capsulitis, no, I would not recommend ultrasound. I would recommend manual therapy, exercise therapy for adhesive capsulitis. I won't even recommend heat. So manual therapy, try and get the accessory movement that you need to depending on whether it's flexion or extension or rotation is always a problem. Look at the accessory movement. Once you get the accessory movement, maintain it with active exercises. You don't need to be strengthening exercises, active ROM exercise to maintain that. But manual therapy, exercise therapy would be my choice for adhesive capsulitis, not EPA. Some latest machines have combination like two pads and J-screamer between IFT and ultrasound. This is something that when I found this device in SGH when I started working there, and Albert, I think some of you will remember, he's still there. He was a chief physician. He was very, very proud of this device, and I could never understand combination therapy. When you combine therapy, whether it's with thermal and electrical, when you combine that, you lose control of both energy. And I can give you a very simple example. You know that as the tissue temperature goes up, skin impedance will drop. So when you start at first, and you put your electrical stimulation and you switch on, let's say at sensory, so they feel a tingling sensation and you stop there. And then after 5 minutes of the heating effect that you get, the impedance goes down. So then more electrical energy can enter the tissue. Then they start to feel twitching sensation because the energy has gone up. So you lost control of the electrical energy by combining the thermal with electrical. And in the first place, why do you need to combine? Are you in such a hurry to go home and have your... I don't understand. Why can't you do one or the other, or both of them, but don't have to be in combination. So you're saying, but the patient only has, like 30 minutes of treatment. In my hospital, I have to see them in 30 minutes and out they go, for example. So choose between one of them. What is your aim that you want? Because both of them have very different aims. The thermal effects and the electrical effects are very different. If you wanted to treat pain, just go with TENS. If you wanted to treat more about tissue elasticity, just go with thermal, for example. So there's no reason in my mind that you need both. If you wanted to treat inflammation, I would not use electrical. I will use ultrasound at low dose, as what you saw earlier on. So based on your aims of treatment, there is no good justification to combine. Definitely, there's no combination. So don't combine. Don't get seduced by them. They'll tell you, if one is good, two is better. Together, they give you multiplication. They multiply the effects. No, they don't. They actually make you lose control of the energy. And when you lose control of energy, you're not doing a good treatment at all. I think we are almost at the last one. Andres, bye, Andres. If the duty cycle is not taken into account into dosimetry, how can we be sure that acute tissue is not visible? Yeah, so go down all the way to 0.1, 0.2. When you do a duty cycle, and I told you this before, when you do a duty cycle, what was the dosage that you set? Is it 0.5? So if you say 0.5 at 50%, you can do the same thing at continuous. So 0.2 at 100%. That will give you the same energy that you want. And I've already shown you on the graph as well, the pulse, maybe I didn't have time to show you, but the total energy, what we look at is the total energy. Total energy is important. And when you start introducing pulse and duty cycle, this total energy thing is a great having, because if you don't have, just keep to 100%, I can control the total energy. When you enter the pulse, there's so many combination of pulse, you're just making it complicated and for no good reason. So if you didn't want a high thermal effect, you want too much energy, bring it down to 0.1 or even 0.2 if you like. It can go down to 0.1. That we know machines can do that. But none of us are comfortable doing 0.1. We feel like, you're not doing much at all, 0.1. But when you do 0.5 at 50%, you feel like that's a lot of energy, which it isn't. So it's a perception thing, I believe. And it's hard to convince people don't do pulse, because they keep saying, but there's a non-thermal effect, not at pulse. Non-thermal is cavitation, microstreaming, and acoustic streaming, not at pulse. You're not going to get that at pulse. So they mix some of these misconceptions with what they think they need to do, what they were taught, those things, and they bring that into the clinical practice, and therefore we reduce the effectiveness of ultrasound by not applying it properly, not understanding the physics, and definitely not doing justice to this type of energy that I think has a lot of potential, but we need to do our work and come up with the clinical studies after we finish the dosimetry model. After you understand and you follow the. Now, I'm not saying that dosimetry model is a final version. It's not. And it will be improved. It hopefully will get better as we go along. But it's a start. And it's a start. It's a logical start, because the reasoning is there. Why this? Why not this? Why this? It's there. I've not seen that. When I was a student, I definitely did not see that. And when I started using it, I didn't see that as well. When I started doing research on it, it definitely was a trial and error thing. So that means we are doing trial and error in clinical practice as well. And that's, I think, not good enough. Hi, Jackson. Good night. Okay. Okay.
That's great. I think we have addressed to all the questions. There's just one missed out. I think somebody asked about, there are a lot of online, home care ultrasound units available, and how effective they are.
Sorry, what, online home care?
It's a question from Moili Tan. There are many ultrasound home units for sale online. How effective those are?
Okay. As I said earlier on, your BNL, your reliability, those are important. We can sell you ultrasound machines from made in China and so on, but when you test it, the output is so unreliable that it actually is a toy. It's
exactly, Dr. Aching. I mean, the amount of the price they put tag on those ultrasound, you can't even buy the crystal, a decent crystal for that price, which is actually fitted in good quality ultrasound. And these crystals really determine the property of beams that are generated.
Yeah.
And they go through a rigorous process of screenings. And to my understanding, they are like selecting diamonds, so they must meet certain criteria.
Yes.
Others are filtered out, and the good one goes in, and the low the BNR, the better the crystals are.
Exactly. Yeah. Maybe the ones that is being filtered out are the ones that they are making online and selling.
Yes, exactly. Throwaways.
So, okay. Yeah. I think good things are not cheap. I think you have to pay for good things, and even shirts, and you have to pay for the quality. And if you're not willing to pay, then don't grumble if you don't get the effects that you want. But don't blame the device, obviously.
Okay, great. Thank you. I think we really had very uh, informative talk from you. And I am always admiring your passion about ultrasound right from the days you were working in Singapore Armed Forces, Dr. Acheng. I've seen you so passionate about it. And that what keeps the industry and profession going. And we need more people like you. Thank you very much. Always being with us.
Thank
Thank you.
you. Good night.
Good night, guys. Bye bye.